It starts with observing the patient. Watch what the patient does, watch how the patient moves. I'll just have you come on over here, walk over and sit down for me. And essentially all I'm looking at is the ease of movement and the way in which the patient sits. I'm comparing this to what I was told on the history as to how well he sits, how much comfort or discomfort he's having. Stand up for me. Have a look at the back. Check it for alignment, check it for scars, check it for discoloration. It's a pretty good rule that if the deformity or the changes are questionable, if you have to argue about whether it's important or not, it doesn't matter. The things that matter are very visible and very obvious. After we've observed the patient, the next thing we're going to do is look at movement. So I'm just going to have you stand back in the middle here, turn around, and I want you to bend down and touch your toes and come back up again. Now, what I'm looking at is the rhythm of movement and whether or not that reproduces the typical pain. So do that again for me and tell me whether or not that causes your pain, the pain we've been talking about. No. Okay, come on up. So that does not reproduce your pain. Okay, do it again. You can repeat this movement 3 or 4, half a dozen times. If it reproduces the typical pain, that's enough. You can stop. If flexion doesn't do it, we'll try extension. Put your hands on your bottom, and I want you to arch backwards, look up at the ceiling. It's a common mistake to have the patient put their hands in the small of their back, which basically blocks the very thing you're trying to look at. So have the hands here, push the hips forward, keep the knees locked, and assess the low back extension. And again, I'm not looking at range, I'm looking at reproduction of the typical pain. One more time. Does that cause any of the pain that we're talking about?
No.
Good. Okay, flexion and extension. There are other back movements, but for the assessment, these are the two that matter. The next thing we're going to look at is going to be the irritative test, the straight leg raising. So I'm going to have you lie on the table on your back. It's important when you're assessing straight leg raising that you always bend the opposite leg. This changes the position of the pelvis, and it actually lets you get a more accurate assessment of whether that hurts. Does that bring on your typical pain?
No.
No. Down. The other side. Does that bring on the typical pain?
No.
There are two variations of this that are important to note. One is well leg lifting, which means that if he's having trouble on the left side and I lift the right leg, I can send the pain into the left leg. That's an indication of a very irritated root. It doesn't mean anything more, but it does indicate that he's having a lot of trouble. The other one, which is much more significant, is if I lift the bad leg and he feels pain not only in the bad leg, but also into the normal leg, into the good leg. So now he's really got sciatica, leg pain on both sides. And that crossing over to the good side is a very serious sign and a possible indication of an acute cauda equina syndrome, something that we must be very aware of. The other irritative test is the femoral stretch. I'm going to have you lie on your stomach for me. In this case, the history will have already told me that he's having pain in the front of his leg. It's leg-dominant pain, but it's pain in the front. The test is simply to lift the leg backward, which puts tension on the femoral nerve across the front of the pelvis, and if it's positive, reproduces the anterior thigh pain. In both cases, straight leg raising and femoral stretch, it's not back pain. This test often causes back pain in patients. That's not a positive test. The positive test is the reproduction of the typical leg pain, anterior, front of the thigh pain, that he's told me about on the history. Okay, have you stand up again. Now, when we come to talk about nerve conduction tests, it's important to recognize that most of the nerve involvement in low back is either L5 or S1, about 80%. Sure.
Can you do the femoral test when he's standing?
Can you do it when he's standing?
Femoral stretch when he's standing up.
If you do it when he's standing up, they tend to rotate their trunk, and it's harder to control. I get a much more accurate reading when he's lying down. I mean, if I get him to push his leg backward, I can do that, but then he can cheat by rotating on his other hip, and it's much more difficult for me to know just exactly how far back it is. The femoral stretch is only useful if the history has already said, this is where I hurt. He comes in, the patient says, I've got constant pain right here. I don't do a femoral stretch on someone who has no anterior thigh pain. It just doesn't, it doesn't make sense, because there's never going to be a positive test, because I have to reproduce his typical pain, and if he doesn't have anterior thigh pain, I can't reproduce it. So I use it only when the history indicates it. As with all the physical, it's to back up my history, and I do it lying down because that gives me better control of just how much the leg is actually moving, how much tension I'm putting on the femoral nerve. Okay? Good. Now, when we look at the conductions, the first one would be L4. I'll have you sit on the edge of the bed. Sit back so your feet are free. And obviously, L4 is the knee reflex. Very simple, very quick, and that's pretty much all you need to do. L5 is, first of all, the hip abductors. And to do that, my preference is to do a Trendelenburg test. Now, this is a very useful test. It is done by having the patient stand. I sit behind the patient, and I put my hands on top of the pelvis. The test is actually more of a tactile test than a visual one. Most people don't understand that. I'm going to have you stand on your left leg and lift your right knee like you're marching. Perfect. Now you notice what happens. As he lifts his right leg, his right hip goes up. What am I testing? I'm actually testing the left leg. The patients don't get this, and some doctors get confused too. The way to remember this is you test the leg you stand on. I am testing the hip abductors on the left side. So you stand on the left leg, lift your right hip like you're marching, and that raise of the hip is the function on the left side. Stand on the right leg, lift your left hip, and now I'm testing the right leg, the leg I stand on. It's useful in patients who are trying to put a false picture out, who are trying to confuse you. If I say to them, which is your bad leg? And they say, your right, my right's my bad side. I say, good, lift your right leg. Well, they, of course, think I'm testing the right leg, but I'm not. I'm testing the leg you stand on. The test should be symmetrical. So if you stand on the left leg, lift your right hip like you're marching. Hip goes up. Stand on the right leg, lift the left. Hip goes up. That's a symmetrical test. That's normal. That's normal L5 function. L5 also controls ankle dorsiflexion. So I'm going to get you to sit on the chair for me.
What would be the abnormality?
An abnormal test would be one hip coming up. So let's just say that we'll have you stand on your left leg, so your right hip, lift your right leg. Now that goes up. All right? Now stand on the right leg. And instead of the hip coming up, it drops. Right? That is a positive test. That's weakness on the right side. So the left hip, instead of hiking up the way it should, falls. Now, it's symmetrical, and that's important. So if he hikes up on the left side, standing on the right leg, then when he stands on the left leg, the other side should hike up as well. If one goes up and one goes down, that is a positive test. If you want to be very subtle about it, if one goes up and one stays level, that's also a positive test. The test needs to be symmetrical. Whatever I do on one side, the normal side, I should replicate on the other side. Okay, so that's the easy way. I mean, people get all confused with the Trendelenburg. What I say is two things to remember. Test the leg you stand on, and the test is symmetrical. That really does give you the way to start. Now, sitting on the chair, we test the ankle dorsiflexors, and the way to do this is to have the heel on the floor, the forefoot up. Can you see that? The way you do this is to have the heel on the floor, the forefoot up, And then with you holding up as hard as you can, I press down. All right? Now, people are taught, this often happens that you're taught that you do this test lying down. So let me just very quickly have you lie on the bed on your back. And the way you're told is, I'm going to have you pull up and I'm going to pull down. Where we go? Now, he's way too strong. I can't overcome that. All right? Now, I have no idea whether he's actually weak or not. This is not gross, just like a little floppy foot. This is somebody who may have lost 25% of his power. So I pull up, he pulls up, I pulled, pull up, that's it, okay? And basically, I have no way of knowing whether one side is weak compared to the other. The only way I can tell, and this is a very important point, is to overcome normal. If I can overcome his normal power, then I can tell whether the other side is a little weak compared to the normal. Does that make sense? In other words, if I can't overcome normal, I can't judge the other side. He knows it's different. He knows that don't feel the same, but I can't ask him. I've got to objectively tell for myself. So doing it this way doesn't give me the ability to overcome his normal. If you sit in the chair, now I've got the benefit of my arm strength, I've got my upper body weight, I've got gravity on my side. You put your heel down and you hold your foot up as hard as you can and hold it just as absolutely hard as you can. And no matter how hard he tries, keep going. Don't give up on me. Here we go. Hard as you can. Go. All right? Doesn't matter how hard he tries and how much he works at it, ultimately I have to win because it's me, all of me, against one set of muscles. Now I know what he can do on the normal. Now I go to the other side and to see whether it's the same. And that's my objective opinion. That's not him, that's me. And that's the key to all motor testing. The key to all motor testing is to overcome the normal side, and then you can judge against the other. The other L5 function is big toe. So you stick your big toe up, hold it up, and I push it down. Okay? Again, hold it up. This is a fair fight again, but this time I can overcome it because I've got enough strength to break the toe down. So that's L5. Big toe extension, ankle dorsiflexion, and the hip abductor, the Trendelenburg. S1 is the ankle reflex. The best way to do that is to have the patient kneel on the chair. And if I need to reinforce it, what I can have them do is squeeze the back of the chair with their hands. This is just like we do with the knee, with the diagnostic maneuver where you pull. The trick is the timing. He doesn't just squeeze and hold, he squeezes at the same time as I hit. So what I want you to do is relax. When I tell you to squeeze the chair, squeeze, but not till I tell you. Squeeze. And I get a very brisk response. Relax, squeeze. That's a way of bringing out the ankle reflex. Now that's S1. It's an easy test. Thanks. Just sit on the bed for me. It's an easy test, and it's one that you can use, but reflexes once lost often don't come back. So if it's there, if they're both present, that's fine. If they're not, then you have to use another S1 test to see what's going on. Now the other thing S1 does is ankle plantar flexion. So I can have you stand up. I'll hold you for balance. And I want you to go up and down on your tiptoes on both feet as fast as you can. Up and down and up and down and up and down and up and down. And the purpose here is to fatigue the legs. So again, I'm overcoming normal. Now I'll stand on the left leg, which is your bad leg, and I want you to go up and down again 10 more times. And if there's weakness, what will happen is compared to the other side, the normal side, okay, stop, shift sides, he'll be able to do it much easier on the normal side than on the weak side. So again, it's comparing the normal to the abnormal. The other thing S1 does, sit on the edge, just sit face, that's right, is it's big toe flexion. So the test is exactly the same as holding the toe up, except now I have him curl the toe down, curl your toes down, and I pull it back up. And again, I'm assessing the normal power compared to the weak side. So that's what S1 does. Reflex, ankle plantar flexion, and big toe flexion. So those are the basic motor tests. Those are the conduction tests. And taking all of those together, L4, L5, S1, takes almost 90% of all the nerve root involvement in low back. Now the remaining tests, first of all, is the plantar response, which everybody must have to eliminate the possibility of an upper motor finding. You can use any upper motor test you like, but the plantar response is the easiest, so just sit back for me. And it is a scratch on the sole of the foot. It comes up the outside of the foot and across the ball of the foot. It's not a tickle, it's a scratch. You know, patients don't like it terribly much, sorry about that. But you basically come up and over. And you see what his toes do. His toes curl down. And that's a normal reaction. Up and over. That's a perfectly normal plantar response. The abnormal response flares the toes out. And that's what you look for if you're looking for an upper motor finding. The final test to make sure we do it is saddle sensation. In order to be sure we don't have any involvement of the low sacral roots, 3, 4, 5, we test saddle. Very easily done, not difficult. Everybody gets nervous about it. It's very fast. Just lie down on your stomach for me. And what you're doing is testing midline sensation between the upper buttocks. Right there. That's it. That's all you have to do. You feel that? Mm-hmm. That's the test. It's that quick. It's that simple. It's not embarrassing. It's not difficult. And what it does is it gives me a sense of sensation in the middle saddle area. I could wash off the end of the hammer. Away I go. There's no problem. It's much obviously simpler than doing a rectal or anything more extensive. You don't need to do that, but it does, every time I do this, remind me to question the patient if I haven't already. Bowel and bladder function okay, you pee okay, you go to the bathroom okay? Yeah. Right? Always ask the patient, always, because that's one of the important red flag questions. And if in doing your history you've forgotten it, because this is an automatic part of the exam, at this point, it serves as a memory aid, so I'll be sure to ask the question. And that wraps up the physical examination, which, as I've said, should reflect the history. I should hear pain on flexion if he's a pattern 1, pain on extension if he's a 2, normal neurology. If he's a 3, I should have something to show for it, positive straight leg, positive femoral stretch, weakness of L5, S1, L4, and then everybody gets a plantar response to rule out a cord tumor or a cord lesion, and everybody gets saddle to make sure they don't have some low sacral involvement that could affect bowel and bladder.
Excellent.
Thank you. Okay.
Healthy?
Fantastic. Closed. That's basically what I'm doing. I hold this position for a minute and a half. It's a long 90 seconds. The patients don't like it. The old folks get back pain, all of them, and they start complaining, and I say to them, is that hurting? And he says, yes, and I say, yeah, me too, it's killing my shoulder. And then we spend 90 seconds bantering back and forth, and if I get one of the residents to time it, I always blame the resident. You know, I say, what, your watch stopped? You know, come on, and I entertain myself for a minute and a half. When it's done, I take the leg down, you get off the bed and go sit in the chair, and I immediately retest his power. And what happens, it's dramatic, the power's gone. Just weak as a kitten, just drops. The patients don't expect it, and I do it, and they go, wow, what was that? He sits 2 or 3, 4 minutes, power's back, test him again, completely normal. I've never had a patient argue with my diagnosis of neurogenic claudication with a positive pheasant test. It's very dramatic. I had a group of GPs that we ran a course for, and one of the old GPs had pattern 4. And he was a little skeptical till we did it on him, and just exactly that. Normal, weak, normal. So it's 90 seconds of forced lumbar extension, shut the foramen, choke the nerve, weak, and then, of course, as he sits, it comes right back again. So that's a very nice way to demonstrate it. And once you've got that, the patients are, they just buy it. I mean, there's no question, you know, watch what I can do, look at this, now you're weak, now you're strong. They don't argue after that. They know you know what you're talking about. It's a very nice test, very specific. And again, I don't use it routinely, but I use it in anybody in whom the history is when I walk, my legs, blah, 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 the whole pattern 4 stuff. Then I'll always do a pheasant test. Okay?
For the well leg and the contralateral,
Right.
do you keep the non-leg that's being raised bent for both of those?
Yeah, I do, because they are so sensitive. I mean, one of the things that people don't get is if you've got sciatica, and particularly if you've got a central cord or an acute well leg, you're in real trouble. I mean, you know, these tests, I teach them, but I wouldn't worry about them in someone who's back dominant. I mean, I wouldn't even bother. You know, I'll do the straight leg raise, that's an automatic, but I will never bother worrying about crossover and all that stuff in someone who's just got back pain. Now, if I do straight leg raise and the guy's screaming at me at 30 degrees, then absolutely, I'll do well leg and I'll listen for crossover, I'll ask him. Because you have to ask him, say, where's your pain going? Down your leg, anywhere else? Yes. You know, again, you've got to take the history and you've got to do the physical carefully. It's so easy just to run right past this stuff and not see it.